Hello, my name is Simona, and I'll be presenting on the global disparities between first and third world countries in convolutional neural network early disease detection. To start off, a little about me is that I'm a rising senior in Austin, Texas. I'm a saber fencer, and I'm also the founder of Young Women in Medicine, a coalition of 2,000 young women who seek to defy gender gaps in healthcare. And I am also the founder of Research Her, a research symposium and organization that brings together young girls who want more access to research opportunities. We're just about to finish our last cycle of our symposium, actually, where we had the honor to host professors from Harvard, Duke, and UT Austin. Lastly, I conduct both independent and mentored research on HIV, specifically the use cases of unsupervised AI modeling in HIV cell lines. Before I get started, here's the outline that I'll be presenting with. Although some of you may already be aware of what a convolutional neural network is, I'll just give a quick summary and its real-world applications. I will also be talking about health disparities and possible solutions, finally ending with my conclusion. To get started, convolutional neural network, or CNN, is what I might be describing about it later on, is a deep learning architecture specifically designed to process 2D medical images and extract them to be categorized into spatial hierarchies of features, utilizing specific indicators depending on the purpose. It is typically used in radiological interpretation tasks like mammogram analysis. As you can see in the slide, the process of neural networks is pretty standard. You, of course, input your images and then the neural network looks for small patterns that may give indications for an abnormality. From there, it looks for certain features and classifies them into a hierarchy. Finally, it is outputted to hopefully a radiologist who can then give more specific advice on how to proceed with diagnosis. Here are two use cases that I find extremely interesting. The first is with mammography testing, in which neural networks are used to find lesion detections and conduct risk assessments. It can happen during any point of a patient's mammography. There's already several commercially available software, such as Inception V3, that can identify certain clusters and turn them and understand if they are benign or malignant. Although mainstream use of the software and many others are still under clinical trials, we'll hopefully see them in mainstream clinics in coming years. The second is fine lesions. They are typically performed through manual perspective visual inspection of thousands of CT images and their corresponding cross-sectional slices. However, manual review can delay diagnosis and treatment planning, posing risk in cases where timely intervention is critical. Thus, the use of CNN, or convolutional networks, has shown promising prospects. As demonstrated through a case study by Holger Roth, in which he addressed the main problem of CNN, which is false positives, by using several basic measures, he was able to avoid common misdiagnosis while also maintaining accuracy, as shown in the graph to the bottom right. So now that we have gone over the mainstream uses of CNNs in first world classes, now we can go into how they aren't being used in third world countries. Displayed on the graph is the concentration points of CNN data centers. As you can see in North America and Canada, China, there is an influx in data centers, as well as in countries in Africa and Middle East, there's close to none. The effect of this is vast, as without data centers, the optimization of neural networks and AI can never be fully applied in clinics in these areas. Furthermore, in addition to disparities with infrastructure, there is also several offsetted effects. A major one is the lack of diverse data sets. Although this has been brought up quite a lot in the past decade, it is still proliferated with AI and CNN's dependency on datasets and incurring misdiagnoses because of it. Thus, with most systems being implemented in select regions, the lack of diverse applications remain a big problem, leading to many hospital administrators in these regions being cautious and assuming the models are overgeneralized, especially in places like rural Africa where AI isn't developed as frequently. This hesitancy mixed with bad infrastructure leads to a lack of inclination of people to use these models in their clinics. Furthermore, there's a significant lack of coverage in these low-income communities. While many CNN models in first world countries have enormous amount of data centers and viable ways to store a variety of diagnostic models, places in third world countries, due to their lack of proper data centers and low infrastructure, leads to very few CNN models being actively implemented, which means there is a narrow scope between the accuracy and dependency of these models. For example, in 2022, WHO released a few studies reporting that fewer than 10% of African hospitals had access to CNN-assisted diagnostics, and even fewer had the bandwidth to support them, leading to a much higher reliance on manual intervention. Finally, and the factor that I would consider the most important is the educational disparity. While CNN models in high-income countries thrive on strong funding and infrastructure, many low-income areas lack the resources and training to develop or deploy their own based tools. This creates a major knowledge gap, excluding local researchers from shaping AI tools that could potentially greatly benefit their communities. A major instance of this is in a 2023 Lancet Digital Health interview, which they found that less than 3% of AI imaging studies included authors from third world countries in Africa and the Middle East. These factors combined made it increasingly difficult to implement these models in low-income countries and communities. Thus, a solution will need to be implemented. The solution that I found that was the most mainstream and the one that is currently still being implemented today is actually two-pronged. It combines utilizing IaaS models and educational programs. IaaS models are basically a pay-as-you-go system. It involves renting hardware resources like servers, networks, and storage from cloud providers and paying based on usage. This can be particularly beneficial in combination with educational programs to teach locals on how to implement these models and how to effectively utilize them. These two solutions lower costs while increasing agility and flexibility to scale for low-income communities. Examples of the solution already succeeding have been shown by AWS Health Equity Initiative and Microsoft in collaboration with G42 in Kenya, who have already shown improvements in care clinics by expanding cloud credits and training locals on how to use cloud and CNN performance models. Specifically, AWS Health Initiative has greatly improved maternity clinics in certain areas of rural Africa and has seen a significant positive impact on their respective clinics. And here are some photos that I found greatly inspiring. And even though AWS is a major industry and spend millions on this, it still goes to show that by using our unique talents in our respective skills in teaching and engineering, we can be able to accomplish a lot of great things that can benefit a lot of people. And this is where I close off. Here are my references going from which slide I use them in. And thank you to both my professors and my STEM mentors who helped me and educate me in specifically AI and ML ops. And thank you for listening. And here's my email if you wish to reach out. Thank you.